Just gone 6 o'clock. Good evening and welcome to the next in the ASGBI webinar series. This evening we've got a focus on patient safety and we're grateful for GE Healthcare, who are our sponsors, and I'm going to talk us through improving patient safety with the use of continuous monitoring. I'm Sonia Lockwood and I'm the Director of Emergency Surgery for the ASGBI. Our first speaker this evening is Dr. Frederic Michard. He's got a background in critical care. He was trained in Paris and has worked at the Massachusetts General Hospital in Harvard. He's an inventor of the pulse pressure variation parameter, which has been used to guide fluid-directed therapy since that time. He's also a founder and managing director of MIC, which is a company that specializes in digital innovation in medical appliances. And he's going to talk us through how medical innovation and appliances can be relevant to a surgical patient. Thank you, Dr. Michard.
Thank you very much for the invitation. Okay. You have it?
Yeah.
Fantastic.
Super. So you can tell us what we should be monitoring, please.
Okay. Well, thank you so much for the invitation to speak about wireless wearables on the wards. I'm going to use a mnemonic monitor to first remind you why actually we should upgrade the way we monitor patients today on the wards. As you know better than me, many patients go to the hospital for surgery and have to stay for complications. We know from the large international surgical outcome study that around 17% of surgical patients develop at least one postoperative complication. It's 27% after a major surgery. So as a matter of fact, many high-risk surgical patients develop postoperative complications, and these complications may be detected with a delay, mainly because of the intermittent nature of spot check done by nurses every 4 to 8 hours. Now we're able to monitor vital signs continuously. We can also quantify how much we miss when doing these intermittent spot checks. So this is a very interesting study from the Cleveland Clinic. As you know, the Cleveland Clinic is one of the top hospitals in the world. And in that case, nurses were spot checking vital signs every 4 hours, and they realized they were actually missing 82% of hypoxemic events and 79% of hypotensive events. So opioids, we all know that, may induce respiratory depression, and there is today a consensus to say that no patient should be harmed by opioid-induced respiratory depression. Here I will simply quote Dan Sessler in this editorial published a few years ago in Anesthesiology. It is likely that many catastrophic respiratory events could be prevented if we were monitoring continuously respiratory variables. The nurse-to-patient ratio is very often suboptimal on the wards, and I like this systematic review published in Surgery, showing an inverse relationship between failure to rescue, that is to say deaths related to postoperative complication, and the nurse staffing level. So here we have two options. We can either increase the number of nurses working on the wards, or we can try to change to upgrade the way we monitor patients on the surgical wards. In-hospital cardiac arrests often occur on the wards. As an intensivist by training, I tended to believe that most arrests were occurring in the ICU or in the emergency department in very acute settings. As a matter of fact, according to this audit done in the UK a few years ago, 23,000 in-hospital cardiac arrests and more than half occurred on regular wards. There is, as you know, a trend towards the admission of older patients with multiple comorbidities who are obviously at high risk of clinical deterioration. And overwhelmed ICUs cannot always cope with a surge of acutely ill patients. It became clearly obvious during the pandemic, and that's why with Bernd Sogel from Germany and Benoît Vallée from France, we propose not only to increase the number of ICU beds, but also to upgrade the way we monitor patients on regular wards. And the last letter from the mnemonic is for remote and wireless monitoring solutions. I mean, that's the good news. There are now technologies available to monitor patients continuously, automatically and wirelessly. So which variables should we monitor more closely? There are different ways to answer this question, but to keep it short, I'm just going to share with you a very large study using a machine learning algorithm trying to predict severe adverse events, for instance, cardiac arrest, ICU transfer, and death after surgery. And in these studies, they ranked vital signs according to their predictive value. And you can see that respiratory rate was ranked number 1. It's actually not really a surprise because we know that the respiratory rate is very often abnormal in many different clinical situations associated with postoperative complications. For instance, a decrease in respiratory rate in patients receiving opioids, but also an increase in respiratory rate in patients developing respiratory complication in sepsis, metabolic acidosis, shock, and so on and so forth. So not a specific variable, but a variable very sensitive to early clinical deterioration. Unfortunately, I mean, it was until recently the neglected vital sign. But the good news is that over the last, I would say, 5 to 10 years, many different techniques have been proposed to improve the way we monitor respiratory rate. But clearly, it's important to bear in mind that all these techniques were not created equal. So here you have the example of an adhesive patch that is measuring respiratory rate using ECG variability and accelerometer data. And you see in these validation studies, on the x-axis, you have the reference respiratory rate. On the y-axis, you have the measurements from the patch. You see a pretty wide distribution with only 77% of the measurements part of the safe zones A and B of the Clark-Kerr grid. With this system, which is based on impedance pneumography and is also a mobile wireless solution, as you can see, the results were very different. Again, the reference value on the x-axis, and you see over 99% of the measurements in the safe zones A and B of the Clark-Kerr grid. So why that? Probably because with this sensor where you actually record more than one signal. For instance, you record an abdominal channel and a thoracic channel. And so if for any reason you don't get the information from the first channel, very likely you will get it from the other. So you understand that we are entering a new era. We could name the World Monitoring 3.0. There are many different options today on the market. But one of the key questions is to know if we can really improve patient safety when using these new techniques. So it's important to really understand what we actually buy when using these techniques. We buy time to prevent severe adverse events. So the idea is to detect very early, at a very early stage clinical deterioration, to have time to prevent rapid response team calls, ICU admissions, and cardiac arrest. As a matter of fact, there are already large studies reporting clinical outcome benefits after the implementation of continuous monitoring on the wards. I mean, this is a table we published with Scott Kalkman a few years ago, and at that time, we were able to collect at least 5 pretty large studies. These are not randomized controlled trials. As you can see, these are before-after comparison studies, but they all reported some clinical outcome benefits from a decrease in rescue events, a decrease in ICU admission or hospital length of stay, or even death in the study from Sube done in the UK. That's an updated table to be published soon in the British Journal of Anesthesia Education. We have today at least 9 large studies. You see a total of over 150,000 patients reporting some outcome benefits when using continuous monitoring, and most of the time, as you can see, with wireless systems. This is a very recent study we published just a few weeks ago. It's a work from the team of Ashish Khanna in the US. This is the first, I think, propensity matched study comparing patients with or without continuous monitoring. And you see in the group of patients with continuous wireless monitoring, we actually observed a significant decrease in a composite outcome of ICU admission and mortality. So far, I shared with you the opportunities when using these techniques. There are obviously challenges as well. So to better understand what could be the challenges, we did a couple of years ago a survey. We surveyed a large number of anesthesiologists from Western Europe and the USA. We got feedback from over 1,000 anesthesiologists. And to the question, what are the main implementation challenges? You see the first answer was economic. They were concerned by the cost associated with this new monitoring system. So it's important to realize that, and that's a modelization study, that if we observe the decrease in ICU admission, the decrease in hospital length of stay, which has been reported so far in observational before-after studies, we can expect, at least in the US, to save around 3 to 6 million a year for a typical size US hospital. And this study, I think even more interesting, is a real evaluation, a real cost evaluation done in the US. So it's small medical surgical ward, but they started to use continuous monitoring on the wards, and they actually realized it was associated with significant savings ranging between $200 and $700 per patient with an hospital break-even after 6 to 9 months. The second big challenge, at least in terms of perception, is connectivity or IT. We're all aware that we may have issues, for example, when using Bluetooth. So this is the example of a study where they monitored 22 patients over a 7-day period with a patch using Bluetooth connectivity protocol. So when it's green, it means actually they were able to collect most of the time the information, the signals. And when it's red, as you can see for other patients, it was a big challenge, a big deal. Most of the time, actually, they were unable to record physiologic information. So clearly using Bluetooth might be an issue. So for the hospital, for monitoring on the wards, I think we need medical grade connectivity protocols, and some are now available on the market. The third big challenge could be the nurse pushback, because very often when you discuss with nurses about continuous monitoring, they have in mind existing solutions we use today in the OR and the ICU. I think it's important to realize these new systems are very different, including smart algorithms, which are designed to filter artifacts and prevent false alarms. Last but not least, I like very much this feedback from anesthesiologists to the question where alarms should be heard. Only 12% thought that actually they should be heard in a room. And I think that's also something very important to remember, that alarms have not been designed to disturb patients or increase their level of anxiety. They are designed for clinicians. So we need systems able to keep silent in the room and to send the information directly to a central station or actually to the smartphone or the pager of the nurse. So in conclusion, I hope, like me, you think it's time to rethink the way we monitor a patient on the wards. On regular wards, clinical deterioration may be overlooked for hours, mainly because of the intermittent nature of spot check. Finding patients before they crash is probably the next major opportunity to improve patient safety. Wireless solutions now exist for the automatic, continuous, and mobile monitoring of vital signs. They may help us to improve patient safety and satisfaction, and to decrease ICU admission and related cost. So is it time for hospital with smart systems? Just to quote Meera Joshi, who is the next speaker, the technology is arriving, the health needs are increasing, so it's time to consider the implementation of this technology is now. I fully agree with that. So if you consider implementing one of these systems, here very briefly is my wish list. You need first a mobile system. So don't think about capnography, bed sensors, or video monitoring. Why do you want a mobile solution? Because early mobilization is a key element of enhanced recovery program, right? So we need mobile solutions with a gateway able to transmit the information to a central station or directly to the nurse. They have to be comfortable to wear, otherwise patients will never accept them. They have to be easy to use, otherwise nurses will never accept them. We need medical-grade connectivity protocols, so exit all solutions relying on Bluetooth connectivity. We need a silent mode in the room to ensure patients recover in a friendly and quiet atmosphere. And we need, of course, systems able to transmit the information automatically to the electronic medical record system, so that scores like early warning scores or even more sophisticated scores can be calculated automatically. With that, I thank you very much again for the invitation and for your attention. Thank you.
Thank you, Frederic. I mean, it's an incredible talk that you've given us. I've got lots of questions, and I'm sure the audience and participants have. For those that are new to ASGBI webinars, if you do have some questions for our speakers this evening, please use their expertise. You can put either into the chat function or the Q&A function in Zoom, and we'll put those to our panelists at the end of the session. Moving on from our last poll, we've got a second poll for you, which we're just going to bring up, which is just to have a little think about where alarms should be heard and seen. And I think that it should be visible for you in just a second from our technical team in the background. So we've had a little look at which monitoring, and you were all correct. It should be respiratory rate. Came in second. So respiratory rate rather than heart rate of end of poll 1. And then to poll 2, please. Who should those alarms go to? So if we're going to have continuous monitoring, it's only worthwhile if someone is there to actually pay attention. You've just skipped on a few, I think, Vicky. So that's poll 4. And go back to poll 2, please. Perfect. Alarms. So where should they be heard or seen? Who should be the people to respond to them? So we'll have a couple of seconds while Meera gets ready to share her screen, please, Meera. Interesting. So command centres, for those of you that have one, we do in our hospital. Quite remote from the surgical ward. A central station on the ward. A nurse or doctor's smartphone. But not the patient. So the patient shouldn't know that they're actually not well. So a central station somewhere manned on the ward looks like it's hip favour. So we'll call the poll an end. And that's about 54 of you who said that, or 54% of you have said that. And then we'll go to Meera Joshi, who is our next speaker. Meera is a consultant oncoplastic breast surgeon working at the Imperial College in London. She's got an academic interest in digital technologies and has actually done a PhD looking at optimising the identification of an acute deteriorating patient and sepsis with the use of digital technology. So well versed to talk to us about how we may improve patient safety with continuous monitoring. So Meera, I'll hand over to you if you will.
Thank you so much, Sonia. Thank you to ASGBI for letting me do this talk, to GE and of course Frederic. It's great to be on a panelist with him as he is very much an expert in this field. So I'm an oncoplastic breast surgeon, but also a general surgeon, and have seen patient deterioration throughout my career from all phases. So I've had a very keen interest in looking to see if we have new technologies that can help us with this. So we know that surgical systems are constantly challenged at the moment. We know that there is burnout with staff. 92% of nurses are feeling very incredibly stressed due to staff shortages. We know that there are strikes. Many of us are sort of filling in at the moment this week, and all of this has challenges. Coupled with this, the remote monitoring or vital sign monitoring hasn't really changed in the last decade or so. There are also numerous challenges to the management of surgical patients. We know that this was a really good paper produced in the BJS relatively recently, which shows that increasing challenges in surgical patients and those with obese patients in particular, and this can affect all bodily systems from mental, hypertension, heart failure, metabolic syndrome, coagulopathies, hypoventilation and respiratory disease. So we're often treating very high risk patients. We know that there are lots of complications post-operatively. Most of these complications occur after surgery and in the ward setting. And we know that adequate monitoring, just as Frederic mentioned, is really crucial because it gives you time. So identifying deterioration gives us time to act. Sepsis is a major cause of morbidity and mortality, and we know that the severe sepsis is as high as 1 in 4. There's a lot of data to show that it's really time critical. So for every hour's delay, the risk of death increases by nearly 8%. It's a common cause, unfortunately, of patient deterioration, and it often makes the newspaper headlines on a weekly basis with regards to it being a hidden killer or missed. Typically, the causes of infection in our surgical patients are pneumonias, urinary tract infections, and wound infections. There are systems in place to help try and identify unwell patients sooner. In the 1990s, the Royal College of Physicians established the National Learning Warning Score. For those that are not based in the UK, this essentially is used in all NHS patients above the age of 16, and it helps look at illness severity and outcome. There are different early warning scores in different countries, but essentially, here's an example of a news chart, and it looks at respiration, respiratory rates, oxygen sats, blood pressure, pulse, consciousness, and temperature. And the sort of redder or the more red the number, the worse the condition is. The patient challenges are twofold. Firstly is early detection of patient deterioration, and number two, to have a better escalation response. There are potential digital solutions that now are available, and some of which we'll be talking about today. Firstly, there's a great acceptability of monitoring. So we know that a lot of our patients now use wearable technology on a daily basis, but a lot of these aren't quite medical grade, and so we're not really able to utilize these in the healthcare setting. There's a variety of sensors that have been tested before. Just as Frederic mentioned, some of them aren't so useful if they're not in ambulating patients. So the early types of sensor were those that were under the mattress, which is great whilst our patients were lying in bed. But of course, with enhanced recovery, we want to get our patients mobilizing as quick as we can. And this is why we're looking at more remote monitoring devices and wearable tech. So we did, as part of my research projects, we did a quite a large patient study with 700 patients recruited, and we were looking at the reliability of a wearable sensor platform and comparing it to nursing observations. This was a cohort study at Imperial. We looked at both medical and surgical patients and those that were based in the hospital for at least 24 hours or more. These were identified by the clinical team, and we compared wearable sensor technology to normal bedside observations. And we found actually that there was a good comparison using the technology that we had. Of note, it's also really important to think about specific cases in breast where I think wearable technology would be useful. So here is an example that I've come across quite recently of a lady. Sorry about this being all breast patients for those colorectal members in the team, but this is a 75-year-old lady that was awaiting breast surgery. She was just required conservation surgery and a sentinel node biopsy. She was really high risk, and we would normally do her first on the list as a golden patient. But she had COPD, cardiovascular problems, previous sepsis, and an ITU admission. Unfortunately, she developed carbapenemase producing Enterobacter, and we had to do a last on the list. Otherwise, we would have needed a deep clean in theatres. This essentially meant that I had to keep this patient in, and I would normally have just sent her home, but because we did her so late in the list, and I feel like actually continuous monitoring would have helped give me the encouragement to be able to discharge her sooner and not keep her in hospital overnight. And that could certainly help with some of the cost savings, potentially, of some of the devices. Here is another case actually that I've operated on this week, an 88-year-old that had a mastectomy and axillary node sample. Again, she was very high risk. We managed her on endocrine treatment for 4 years. She had a TAVI, lots of comorbidities, and was on antiplatelet treatment. She stayed in overnight. Perhaps if I had more continuous monitoring and I was able to get greater vital signs for her, I would have been able to send her home. She did go home. She did become slightly unwell at home. And then this also leads to the question, as wouldn't it be great to get wearable technology in the home setting, not just for patients within the hospital? And that could certainly help both in the elective and the acute care. As well as this, we did a lot of research on patient and staff feedback, because just as Frederic said, this has to be really acceptable to end users. So if it's great for us as clinicians, it also needs to be acceptable for patients. And we recruited 12 junior nurses, junior doctors that were anything below fellow standard. senior nurses, band 6s and above, and then consultants. And we found, and this was just about wearable technology in general. So the surgical consultants generally felt like this would be the next thing and really improve care. Senior matrons thought that wearable technology would especially help with night cover and weekends cover. And overall, junior doctors thought that this had the potential to pick up patients quicker. And from the junior nursing point of view, it was very much a better way of relaying information, which kind of fits into our poll of where that information goes to and who it goes to. And we did some thematic analysis of this, and we found that everyone realized that there were lots of problems with our current monitoring that we have: missed observations, staff variation, failure to escalate, equipment problems. It was felt that staff impact would help overall improve workload, lead to better decision making and save time. Patient impact hopefully would be positive, especially with night monitoring and weekends cover. And identifying, really the key was identifying patient safety, leading to hopefully better outcomes. And so very much the key theme would be, it would be great to have newer interventions that can help with some of the monitoring compared to what we are doing currently. And this could ideally be used not only in the hospital, but at home, but also in the research setting. We also were really keen to hear what patients thought, and this is some of the feedback from some of our interviews. Depending on the technology, most patients have forgot that they were wearing the sensor. They felt like it didn't really, I think the key is making sure that they're able to ambulate with it. So anything that's wired or grossly restrictive would have impacted their normal function. And interestingly, even when we were doing very preliminary research studies where we weren't alerting to the nurses, patients actually felt safer having this technology on, even though it wasn't alerting to nurses in real time. Overall, the main themes of this were, from a patient point of view, improved safety, earlier detection, the reassurance. Many patients talked about it being a safety blanket. The idea of centralized monitoring was a comfort, especially to patients that were more in remote areas of the ward. Patients felt like it was very much would be the future of monitoring and overall had a positive view. They even talked about extra additional types of sensing that we could use. Comfort and usability was really the key, so making sure that they appreciated that this caused as little hindrance to their day-to-day life as possible. And really, they were quite impressed to see what the staff perception of the wearable technology was as well. I'd like to thank all of our research collaboratives that were involved in this project. So thank you very much for your time. And thanks again to the hosts, ASGBI, GE and Frederic.
Meera, brilliant. Thank you very much. I can already see that we've got some questions coming in through the Q&A and the chat function. So we'll bring those at the end of the session, but very interesting. I like the patient involvement in your study, actually. It's nice to involve them and to see what they think. We think it's a good idea, but it's always nice to see what they think. Continuing with our interactive theme of the evening, we're going to have an attempt at poll 3, which is to see what people think about what the main implementation challenges might be. So we'll have this poll open again for about 30 seconds or more. So if people want to take part, that would be helpful. So do we think it's patients that push back, the physicians or the nurses, what the IT might be, economic factors, and then anything else people can think of? So economic, certainly in the NHS, in the current state of play, I suspect is going to be a major concern. And we might hear more from GE in a minute about how that might be balanced. So we'll share those results. That looks, yeah, connectivity, that would be my issue, certainly in our hospital. It's a Wi-Fi and Bluetooth black spot. Can't get mobile phone signal in many places. So economic, obviously, a major concern. Brilliant. So we're going to move on to our next speaker. This is Aldo Lobozzo, who is from GE. Thank you, Aldo. If you want to start sharing your screen, that'd be super.
Okay, I hope you can see my screen.
Yeah, that's fantastic. Thank you.
Yeah. So thank you very much. Basically, what I'm going to say today is a kind of wrap up and what we have designed at GE Healthcare, considering what our speaker said before. So framing the bigger picture in terms of clinical problem, infrastructural problem, workflow problem. So what we have thought and designed is Portamobile as a solution to deliver mobility to patients. So, and moving to my next slide, what we want to do is to create a platform and a solution that is easy to wear, easy to use, easy to connect, and especially easy to check the patient condition. So because we want to see the patient all the way through 24/7, because we want to identify deterioration at an early stage. The key element is we don't want to transform a ward into an ICU. Otherwise, I mean, the workflow and the situation will be very complicated. And that's why we focus on the most important vital sign, meaning respiration rate, as we have highlighted before, saturation, and pulse rate. From an infrastructure standpoint, what we have focused on is to avoid Bluetooth, as Dr. Michard said before, because Bluetooth is very good from a commercial standpoint, but when we are in a medical environment, we need to have strong, reliable, continuous, and secure data that Bluetooth is not able to deliver. What we understood through the poll and through the previous panels is the importance of respiration rate. And why we focus on respiration rate? Because we understood that it's an early predictor for patient deterioration. And we know that respiratory depression is a top 10 patient safety concern. And it's a kind of early indicator of any kind of adverse events. And especially, we know that in the general ward, patients with respiratory compromise are 29 times more likely to die. So that's why we wanted to focus in there. But we know that traditionally the measurement of respiration rate is not accurate enough, good enough, because simply is a byproduct of the ECG. That's why what we have done at GE Healthcare is to build from scratch a new way to measure respiration rate, starting even from the disposition of the patches. So we wanted to have an accurate data, continuous data, and I mean, as we have seen even before, there's a massive accuracy compared to the capnography. And the same is in the clinical evaluation study that we have run, comparing a different frequency of respiration, our wearable technology with the traditional nasocannula, so the wired technology. So what we wanted to do is to have a solution, a wireless solution as good as wired. Another topic, thinking about the workflow and the amount of job that every single nurse have to do every single day, is having a seamless integration. So there's no point at the end of the day to take a note from a screen with pen and paper and then copy it into an EMR system. That's why we want a seamless integration, so to have continuous data and very easy to access and to analyze the patient. So in a nutshell, if you want to see the whole picture of Portamobile, and I will have another slide after that, and I will wrap up. We want to have a patient that is able to move as soon as possible, and as long as the patient is in the room, they can move, and the connection will be straight to the hub, and the hub will be connected to the hub through the medical body area network. And the hub, thinking like a kind of a medical phone, will be connected to the system through Wi-Fi. So every hub will connect to the sensors of the single patient. The hub will be connected to the server through the Wi-Fi connection, and wherever the patient is, Portamobile follows. So even in terms of rehabilitation, movement, and any kind of activity of the patient, the Portamobile will follow the patient. And all the data can be seen through a patient viewer. So back to the poll where you highlighted the need of watching the data of the patient at a central viewer. all the data will be there in terms of real-time data trends. So in that way, you can see in case of a change of a trend that there's a change, you can intervene and do a deeper dive or in-depth analysis of the patient to understand if there's a potential deterioration or not. So I think this picture gives the perfect idea about how the solution is working. So either in the room or wherever the patient is, we can collect the patient data 24/7 in a continuous, reliable, and secure way. My last slide is around a usability study that we have run recently. And the key point is that, 90% of the people interviewed in this usability study feel more reassured about using this solution, and 99% agree that we can help with Porter Mobile identifying deterioration at an early stage. 96% of the interviewed gave a overall rating of good or very good, and in 76% of the cases are more confident in assessing respiratory function. I would say the best quote that we can get is from a patient saying that no problem at all in using it, in having it, and I didn't even notice they were there. So I think this, what we're trying to do today is to give you a very quick picture about the solution, why we wanted to create it from a technological standpoint, and especially how can be integrated in your workflow in order to have a better patient safety and better patient outcome. So having said that, I want to thank you all and the speaker and ASGBI for this opportunity.
Brilliant, Aldo. Thank you very much. I think it's nice to see some of the actual technology and how it might actually attach to the patient and be used. It's nice to see it connects to some of the existing electronic patient records as well, because I know many people on this call will be using one of those three systems. So we've got a couple of polls to go before the question and answer session. So the first is, if we're going to write a business case, who do you think the business case should go to if you were going to create that? Either the ward manager, the CFO, CEO, CMO, or the chief nursing officer. So see what people think. Chief medical officer for most. Ours is an anaesthetist by trade, so I think they would be very keen to see it. But all of the above, I suspect. Yeah, so things have evened out. For end that poll then, thanks. And then one final poll. We'll go to number 5. Which is going back a little bit. So how important is it to watch a patient's data on a mobile app? Not very important, little importance, average, very important, or absolutely essential. So poll number 5. The case for wearing it. We've not got it. So we're going to go on to some Q&As for the discussion. So if I can bring Meera, Frederic and Aldo back in, please. You can come off mute because we've got some questions come through. So first is come in this evening saying the implementation of continuous monitoring system of a patient with no clear cut-off for ICU admission, but still at high risk for adverse events, would need to be coupled with new ward policies. So do you think it might be that we need to educate nurses how to recognise deterioration in this scenario and what to do until the expert arrives? So I guess that's a reasonable question. Some patients do deteriorate, but they might not be a candidate for escalation, and what to do in those circumstances. So Meera, you've sort of worked in the clinical scenario with this. What would your answer be?
Yeah, it's a really good question. There's a lot of work around education, and there's also a lot of work around nurses, especially quite junior nurses that are often sort of HCAs, that are ones that are doing the observations, not wanting to raise the alarm falsely. So Frederic talked about respiratory rate in particular being a neglected vital sign. And with that, we've all seen in our patients where we just see 12, 12, 12 on the odds chart, and then suddenly the patient crashes. And that very much isn't what likely happens. So I think education is definitely helpful. Getting nurses involved in the process, and we found that when we were implementing the new technology, we had nurse champions for the day. So they were very much accountable for the sensitive system that we were using at the time. And that certainly helped. But there's a huge amount of, I mean, we talked about this just offline, there's a huge amount of work on not only the device and reliability, but very much the human factors behind it. And I think that's really key. So hopefully a combination of human factors work and education and support. And these wearable systems are an adjunct to care, not a replacement. So I think that's really the key. We're not saying, here's a wearable system, the nurses don't need to see the patient for X amount of time. It's very much looking at how the two technologies could, or using what we have now, but also looking at new wearable technology and seeing how it can help.
So just a couple of sort of spin-off questions, really. Is there a way to change the settings, as in the parameters of when that alarm will go off? Obviously, a patient with COPD, their saturations are going to be low and the respiratory rate different. And the second sort of part to that is, we know in a surgical patient post-op, they might have a high Muse score. The junior registrar or junior doctor goes, sees them, implements some form of therapy, but an hour later they're still showing a high Muse score. So can you manipulate the wearables to match the patient, I guess?
Yeah, very much so. And that's a really good point, because also that links in with alarm fatigue. So we want people to go to, or escalation to, the right patients. And if patients keep triggering these alarms, then the nurses will sort of switch off and just think it's a false alarm. So you can very much set the parameters. And looking at some of the systems that I've looked at previously, they can alert to perhaps the HCA looking after that patient or the nurse in that bay. And then if they're not acted upon, it can go to the senior nurse on that ward before it's then sent to a more junior doctor. So there's always a triaging system, which I found really helpful.
Okay. So Frederic, a question to you, I suppose. The alarm's going off, the patient alarm's going off, but there's a delay in somebody being able to respond to it. And I guess if you're doing intermittent monitoring, the argument is that the nurse or the HCA is present at the time that they do it, and they're free to see that patient. But quite often on a busy ward, this alarm goes off. What's the sort of medical legal standpoint of not being able to get there, or how long would you expect somebody to wait before they then get seen?
Yeah, it's a very good question, but I think the concept is to have nurses to free time for nurses, because we can imagine that in 5-10 years from now, all these vital signs per check will be done automatically. So they should have more time to respond when it's necessary. And so we can imagine that, most patients are remaining stable. Actually, nurses will have more time to take care of patients who are deteriorating. But the scenario you described may happen, of course. And that's why it's important to highlight as well that, what we discussed today is just one piece of the puzzle. It's at least the first part, which is early deterioration. Then the second part is, of course, appropriate behavior and reaction in case of deterioration. And it's also something we did not discuss today because it was not the focus, but it's as important. Rapid response teams typically describe what they call the afferent arm, and then you have the efferent arm. So today we discussed the afferent arm, which is early detection of clinical deterioration. It's also very important to define the process of the response to clinical deterioration. Who is going to receive the information? Who is going to respond? How we are going to respond? What is the process? Should we send the information to the nurse or to the physician working on the wards, or directly to the rapid response team? So I think this is difficult to give a single answer. It depends a lot on the organization in any given hospital. In the US, for example, they even have command centers, meaning that this information will be dispatched automatically to people doing that full time, sitting in front of big screens, and of course, calling the right person in case of clinical deterioration. So it's difficult, once again, to give a single answer. Depends a lot where you work, in which country, in which hospital, who is responsible, who is in charge of rapid response teams. For example, in France, sometimes, anesthesiologists are in charge, sometimes intensivists. So it needs, adaptation. We need flexibility, but clearly the response is as important as the early detection.
Thank you. There's a question from Anonymous. We often get questions from this person. They've asked if BLE can be considered medical grade. So are these wearables medical grade, or are they still in the experimental phase? I guess that question's to Meera or Frederic. You've had most experience of them.
Aldo's just come up as well.
And Aldo.
From my point of view, yes, there are definitely ones that are medical grade. Aldo will tell you about the one from GE very shortly. I think it's just making sure that there are lots of wearable technologies that can be quite gimmicky, so they can claim to measure lots of things, but actually there's no evidence or data on reliability. And I think that's really, really key, using data to drive to see how reliable they are, matching it or comparing it to nursing observations, even if there are small trials. So when I was setting about doing my research, I contacted quite a few of a combination of quite small companies to quite big companies, and most of them didn't really want me investigating their sensor or breaking it apart or finding actually how reliable is it in a clinical, messy setting, as opposed to healthy volunteers sitting at home or in a lab base. So I think that there's a real difference between using these wearable technologies in healthy volunteers, which are often how they're often measured to get their CE markings, but also how does it work in some of our surgical patients with multiple comorbidities. So that's what I feel.
So I guess the thing that strikes me is that we've been bare below the elbows in the UK for 20 years. We're not allowed watches and jewellery, and we're now going to strap them onto a patient. So infection control concerns, and if they're not single-use, sustainability concerns. I'll send that to Aldo, I think.
Yeah, no, we are definitely thinking of this situation, especially from an infection control standpoint. And on the other side, we are addressing the sustainability element to see, let's say, all the way through, not just, the product itself, but the whole production to be, let's say, to have the lower impact possible. So that's part of, let's say, of the journey that as a company we are, let's say, dealing with. So yes, we are going to think about infection control, as we know is an essential problem, is an essential topic, especially the respiratory rate patch is single patient use. So that's a way to even think about infection control, and we are close to deliver a sustainability impact as well.
Okay, so inevitably we've got a question about the cost effectiveness and how much are the economics of it. So give us a bit of a flavour about how much these are going to cost us or set us back, and when you've done any analysis, what the cost benefit is in terms of bed days saved, life saved, ICU, critical care saved. I don't know, Frederic, are you able to give us an idea, please?
Yeah, and maybe you remember I showed a few slides on the topic in my presentation. I think it's mainly about the ability to decrease ICU admissions. At least that's what has been mentioned, most often in publications, and that's clearly what we expect. If we're able to catch up, to catch clinical deterioration at a very early stage, that's what we can, expect is to prevent ICU admission. We know it's extremely costly, and so there are a couple of studies already showing that. Of course, if we effectively decrease ICU admission, it's going to be interesting, not only from a clinical standpoint, but also from an economic standpoint for the hospital.
Yeah, Aldo, average cost of a single patient monitor?
What I can say is we recently published last November in partnership with Chelsea and Westminster an abstract on the cost effectiveness of the system. And according to this abstract, and according to the adoption, so in 100% case of adoption, the cost effectiveness can save up to £9.2 million a year, driven by patient outcome and patient safety. So let's say the saving cost is a byproduct of the improvement on patient safety. And the full article will be available later this year, but the abstract is already available with the data.
Thank you. There's a couple of questions about training staff and how we get nursing staff in particular involved, both learning to use the technology and changing the technology from their sort of 4 to 6 hour observation rounds. You obviously did some work in interviewing lots of members and sort of stakeholders, Meera. What was the sort of comments that came back from nursing staff in particular? Were they in favour, or because I guess we're thinking what they might think, but you actually know, having chatted to them?
So I think overall they were in favour. There are certain barriers, such as making sure that what their main concerns were to do with not being overburdened with false alerts, and that's really the key. So some of which is due to be published later on, hopefully this year, was looking at the number of alerts to be generated. So as opposed to just one alert being sent because there's a slight blip in respiratory rate, having certain time windows of alerts. So for example, if the patient alerts over, say, a 5-minute window or a 10-minute window, and we did a lot of work looking at algorithms and detecting certain thresholds of alerting. So I think as long as we're not bombarding nurses every few minutes with these alerts, because that on top of all of their, as we talked about, burnout, staff shortages, it's probably the last thing they need. But where they found it particularly useful when we were implementing it was having nurse champions on the ward. So each day or each shift, one of the nurses would be sort of in charge of the system setup, and if there were any problems, they were the go-to person that day. I think before I started our research project, I had a year on the wards just talking to the nurses, making sure that they were aware about what we were doing. We had to engineer the wards so wherever the patient was, there weren't any dead spots or connectivity problems. I think all of these factors really helped. And also, it's very much a partnership with industry. So any help that we are able to get with industry in establishing these systems really helped as well. So we had training groups, we had people on the ground to help, not just here's some new tech, we'll see you in 6 months' time, good luck. It's about having people there on a daily basis. So I felt that overall, for it to be successful, it was myself as a research person, somebody that they trusted clinically, but also in the academic setting, as well as industry partners. And it very much is a collaborative. And I felt that that helped drive the project and lead to some successful outcomes for us.
Brilliant. I mean, the opportunities are endless. I think either yourself or Frederic mentioned ambulatory setting. We saw a little bit of that with oxygen monitoring during COVID-19, but the idea that we could virtually monitor some patients ambulatory, get them out of the building, out of the hospital, is a whole webinar in itself. So knowing that I nearly always run over, I'm going to draw this evening to a close. I just want to say thank you so much to Meera Joshi, to Frederic Michard and Aldo Lobozzo from GE Healthcare for coming this evening and doing a great presentation, which will be available on Catch Up for those that want to go back through some of the articles and papers that were mentioned in the talks to read in your own right. It takes me just another minute then for a shameless plug for the ASGBI Congress, which is coming up the 8th to the 10th of May in Belfast this year. If you have not already registered, then the early bird registration continues until the 8th of April. So there is still an opportunity to get a bargain. Please do join. I've seen the programme. Demetrius Damascus has worked really hard with the whole of the ASGBI team. We've got a great selection of speakers. So please do come. For trainees that are on the call this evening, please be aware that we are running an ATLS course in conjunction with the ASGBI Congress. So if you've been struggling to get an ATLS place, then there are some still available. Likewise, SAGES are doing a course, and we have a notes course available as well. So please go to the website and find those. Anyone who is upper GI or HPB have an interest, we've got a course running during Congress looking at CBD exploration. And again, there are still some places available. Please look at the registration and the website for more information. With just a couple of minutes to spare, I'll thank you again to our speakers. Thanks to those of you that have joined, and we'll see you again soon for one of our ASGBI webinars in the future. Take care.
Thank you. Bye-bye.
Thank you.